So good afternoon. I think it's better to start. This is a symposium dedicated to the GitHub project, where for the first time we will present data. This morning you have heard some data from the trial, the piano trial, and in this afternoon you will listen to data from the guitar project, which was dealing with genetics. The contrabass project is it's a pity that we don't have the instruments, but we will get organized for the next Congress. So data from the contrabass project, mainly dealing with brain imaging and cognitive assessment. Then there will be two further presentations, which will go back to the piano project, dealing with life events and psychosis, and predictors and moderators of the effectiveness of the intervention in the relatives. I skipped this morning, because it was too late, this slide, which shows the front page of the book, where we give to the Italian people, but if somebody is interested, the publisher is also available for translations in other languages. All the material that has been used and in the GitHub project, which is readily available. So there are all the manuals for the multi-element interventions. There are the instruments. There are the slides in order to explain the instruments to the professionals, and also data sheets where people who are willing to collect data on their own services can do that themselves, and this will be part of an online appendix which we will keep updated regularly. So sorry for this, but as I'd forgotten this morning, I was wishing to present this part to you too. My co-chairperson is Professor Max Birchwood. It doesn't require any presentation, just to say that his impact and influence in the GitHub project has been absolutely outstanding and fundamental. So I will introduce now the first speaker, Luisella Bocchio. She is from the Fate Bene Fratelli in Brescia, close by, 50 kilometers from Milano. She is also professor of applied biology at the University campus University in Milano. She has been co-leader together with Professor Massimo Generelli of the guitar project, and she is an expert in genetics. Please.
Good afternoon to everybody, and I would like to thank you, the organizing committee, for this invitation. The identification of molecular markers for psychosis in patients' peripheral tissues, behind its utility for the clarification of the pathogenetic mechanism, it may provide innovative instruments in the clinical practice for the identification of subjects at risk to develop a psychiatric disorder, who can be targets of preventing treatments. Moreover, biomarkers can also be helpful in the differential diagnosis of these disorders, often sharing a similar symptomatology, or in the process of personalization and optimization of treatments. The diagnostic assessment in first episode of psychosis patients is complex and often is defined only some months after the onset of symptoms. In this patient, the beginning of an adequate and timely treatment is crucial to prevent the chronization of the disorder and to optimize the therapeutic effectiveness. On the other side, studies in FEP patients may be helpful since since they provided the possibility to identify molecular alterations in subjects at the onset of the disorder, without the complication and the confounding effect of long-term drug treatments. An integrated approach that merges together different innovative omics technologies such as genomic, epigenomic, transcriptomic, lipidomics, and so on, may be successful to provide solid findings in biomarker discovery. This was the strategy that we applied in the GITAR project, a partner project in the framework of the GitHub project that Mirella presented this morning. In this project, we had the possibility to study a wide sample of FAP patients at onset and after 9 months of treatment, with both pharmacological and also add-on not pharmacological approaches. In this study, we had the opportunity to analyze the whole genome profiles in a genome-wide association analysis, as well as transcriptomic data at mRNA level and proteomic signatures in patients' blood. 117 community mental health centers located in 2 northern Italian regions, Veneto and Emilia-Romagna, and the urban areas of Florence, Milan, and Bolzano participated to the project. All the clinical centers involved in the GitHub piano trial were asked to refer potential psychosis cases at first contact during the index period to the study team. The GITAR project was conducted in this enrolled sample in close connection with the GitHub piano trial. In the project, we collected DNA, RNA, and plasma serum sample in patients at baseline when they entered the study and at the time of follow-up after 9 months of treatment. Between T0 and T9, a part of the patients were treated following an, as usual, clinical practice, while others received an experimental treatment with an add-on multi-element psychosocial intervention. Today, I present you the first data that we have obtained on 19 proteomic markers in the sample of patients at baseline. The aims of this part of the project were the identification of proteomic signatures associated to psychosis onset to clarify the pathogenic mechanism of the disorder and to identify new potential therapeutic targets. The second aim was also the individuation of possible molecular markers associated to FAP diagnosis for the implementation of the diagnostic assessment. Out of the sample recruited in the GitHub piano project, 211 FAP patients gave the informed consent for the GITAR studies on blood samples. In brief, inclusion and exclusion criteria were the same of the piano project and are reported here. In parallel, a control group of 49 volunteers has been recruited. Control subjects were not different to patients for demographic characteristics and also body mass index. Out of the 211 patients, 53 received a diagnosis of schizophrenia, 59 of affective psychosis, and 99 received another diagnosis. These 3 groups were considered in the analysis of proteomic data. Regarding the markers that have been analyzed, consistent studies reported an abnormal activation of the immune system in patients affected by major psychosis, suggesting the presence of an inflammatory syndrome in this disorder. An increase of pro-inflammatory cytokines levels have been observed also in drug-naive FAP patients. In this study, we choose to analyze a panel of cytokines and chemokines regulating inflammation as the pro-inflammatory cytokines interleukin-6 and interleukin-17, and the anti-inflammatory interleukin-10 and interleukin-1 receptor antagonist, as well as the chemokines interleukin-8, RANTES, and MIP1 beta. Accumulating evidence shows also abnormal glucose metabolism and insulin resistance in psychosis, even at the onset of symptoms. Moreover, patients with schizophrenia have an increased risk of developing type 2 diabetes compared to the general population, also in the absence of antipsychotic treatment. It has been hypothesized a kind of type 3 diabetes specific for glucose alteration in the brain that may be linked to metabolic abnormalities in neuropsychiatric patients. Alteration of lipid and glucose metabolism and weight gain may be also induced by antipsychotic treatment. For this reason, in this study, we analyze also a panel of markers linked to glucose metabolism and food intake. Regarding neurotrophins and growth factor that can be involved in the neurodevelopmental etiological hypothesis of psychosis as BDNF, the brain-derived neurotrophic factor, or VEGF, the vascular endothelial growth factor. There are several incongruent evidence for a significant reduction of these neurotrophins in major psychosis, and often an increase has been observed, often the treatment with antipsychotic or antidepressant drugs. Coming to the results, the statistical analysis of the data indicated significant alteration in FAP patients for 10 biochemical markers. In particular, VEGF, MIP1 beta, interleukin-6, leptin, and pi were significantly increased, while interleukin-17, GLP-1, glucagon, ghrelin were decreased in the whole group of patients towards controls. No differences were evident among the patient subgroup stratified for diagnosis for these markers. On the contrary, interleukin-6 is specifically increased in patients with an affective psychosis in comparison to other patient groups. A principal component analysis of the 10 markers showing significant differences between patient and controls was carried out to explore the possible pattern in the data set among the markers and to identify which of them may be more useful for the discrimination between patient and controls. Coherently with the results of the univariate analysis, the PCA plot has evidence a separation between controls, circles in red, distributed, and patients that are distributed in an almost unique cloud in the right side, not different among the diagnostic group. A subsequent variable importance analysis was performed to evaluate the contribution of each of the protein markers in the separation between patients and controls, showing that MIP1, ghrelin, glucagon, and VEGF were those mostly altered in patients. Since interleukin-8 is specifically increased only in patients with a diagnosis of affective psychosis, we performed the PCR considering affective psychosis toward other diagnoses, and we did not find a clear separation of the data. The missing of a clear difference between affective psychosis and other patients was confirmed also by the VIA analysis, showing that all markers had a low discriminant power. to evaluate the sensitivity and specificity of the 10 markers to discriminate between patient and controls, we conducted a ROC curve analysis for MIP1, ghrelin and glucagon. The area under the curve was larger than 0.8. In particular, MIP1 beta showed the best discriminant power with an AUC of 0.85. MIP1 beta is called also CCL4, belongs to the family of CC chemokines and is produced by macrophages and play a major role in innate immune response toward infection and inflammation. It can induce the synthesis of pro-inflammatory cytokines as interleukin-1, interleukin-6, and TNF-alpha that have been found increased in schizophrenia and other major psychoses. In central nervous system is one of the chemokines involved in the neuroinflammatory processes mediated by microglia and in the crosstalk between neurons and glia. Recent reports evidence an increase of these chemokines also in schizophrenia and in autism. In the GITAR project, we have available the data on genome-wide association studies of about 1 million of genetic polymorphism in the subsample of FAP patients with a diagnosis of schizophrenia. In this sample, we found 8 single nucleotide polymorphism in the MIP1 beta gene associated to the expression level of the chemokine, suggesting that the differences that we find in this study between patient and controls may have a genetic origin. Regarding the results on the metabolic regulators, ghrelin is a peptide hormone produced in the gastrointestinal tract with a neuropeptide action in the brain. It regulates appetite and also the distribution and rate of use of energy. Ghrelin has been reported to decrease after 6 weeks of olanzapine in FAP patients, while another study indicated an increase of ghrelin after antipsychotic treatment. Also, glucagon is a peptide hormone secreted in this case by alpha cells of pancreas. It has the function of raise the hematic concentration of glucose, inducing the conversion of glycogen into glucose in the liver. Glucagon and insulin are a part of a feedback system that regulates blood glucose levels. Both of these markers can be altered by stress exposure. In conclusion, our data reported the chemokines and metabolic alterations in FAP patients in line with the recent studies that indicated closer relationship in many disorders and also in psychosis between these two systems. First, studies indicated also that no marker of the one analyzed may be associated to a specific FAP diagnosis. In the second phase of the proteomic studies of GITAR, we will focus our attention to longitudinal modification during treatment, as with and without the psychosocial intervention, in order to evidence possible changes during treatment and association of different markers with therapy outcomes and side effects. Moreover, we will go on in the integration of the data coming from proteomic, genomic, and transcriptomic analysis in the project to identify signatures of biomarkers associated to psychosis and treatment efficacies. Now, let me say thank you to all the guitarists, the colleagues of the IRCS Fate Bene Fratelli of Brescia, in particular Roberta Zanardini and Massimo Gennarelli, and also the pianist of the University of Verona, and all the clinicians and the personnel of the laboratories that help us to collect the samples of the GetUp group, and also to the Italian Ministry of Health that funded this project. And thank you all for the attention.
Okay, we have a couple of moments for questions. Great presentation. Any observations or comments? Please, Paul.
What was the
1 minute, 1 minute.
behind the selection?
Thank you. What was the rationale behind the selection of the panel of cytokines? Was that?
Yes, we based our selection on literature data reporting association with schizophrenia or major psychosis, and we tried also to take in consideration the biological patterns. Perhaps we studied MIP1 beta because could induce the synthesis of pro-inflammatory cytokines, and so pro-inflammatory cytokines have been widely studied in psychosis. So we try to understand better some alteration that are already known. And also regarding the metabolism, there are growing data about this kind of alteration also at the onset. We would like also to observe what happens during treatment. So it is important to have this kind of data.
Any other points or questions? Okay, you're off the hook. Great, thanks very much. Thank you.
Thank you very much.
Oh, you need your equipment.
Then the next speaker is Professor Max Birchwood. He has been one of the founders of all the area of early psychosis and also of this association that we are hosting these days in Milano. He is a professor of clinical psychology at the Warwick Medical School in UK, and also is linked to Birmingham University. We are very proud to have this ongoing collaboration, which started from the very beginning of the GetUp project. He, through some of his collaborators, gave a very important contribution to the training for the CBT, and also he gave very important contribution in suggesting some instruments which were very important, then revealed to be very important in the final results. Now we are collaborating in a project which shows one of our doctors in training, now trained psychiatrist, which is now full-time working with Max, and you will see that his presentation goes to the extreme opposite of the previous two, and will provide extremely interesting data.
Well, thank you very much. It has been a great pleasure over the last few years to be involved in your project. I mean, I'm on the advisory board, but I guess I'd call myself an admirer of the project as much as anything else. And it's been great to watch the project unfold over time, and to be here today to see these amazing results. And your presentation this morning was just amazing. And as you were saying, part of our collaboration is that one of your students, one of your psychiatrists came over on a placement with us for a few months, and that's Rosa Ritunano. And she it was really her initiative to look at the data on abuse and neglect and their relationship to psychotic symptoms in the GetUp sample. And we, myself and my colleagues Andrew Thompson and Rachel at the Grove, and as well with colleagues in Verona, helped to formulate the questions and to work with Rosa to develop the analysis. But as you can see, these she wasn't going to be able to be here today, so she's. I'm very pleased to be able to present this on behalf of the team. Also interesting what you were just saying. It's fascinating how I mean, one of the biggest things that people often ask me, having spent most of my career in working in schizophrenia, what's been the biggest? Is there any big breakthroughs, the biggest change that you've noticed? I always answer the same way. When I started my training long time ago, 30 odd years ago, we'd just come out of the era of intense psychoanalytic psychotherapy, that kind of era, and then it led to the Chestnut Lodge study, and then the biological movement really took off very, very powerfully and has been very powerful and dominant and influential. But in the last 10, maybe 15 years, what's become increasingly clear is that there are powerful social gradients that are involved as risk factors in the development, but probably also in the course of psychosis. And these are now very well understood and widely accepted. These are, for example, urban upbringing, being a migrant into a new society, or indeed, if you're a second or a third generation migrant and you're socially marginalized, as some individuals are in the UK, this continues to yield a higher risk of psychosis. And so where I have worked a long time in Birmingham, the middle of Birmingham, the third of Birmingham, which is the poorest area where people have been born and brought up, is a third of the population of Birmingham, has 2/3 of the psychosis. So there are some very important social gradients that we're only becoming to understand. And just to finish off that introduction, I was chairing a symposium this morning where a young presenter from Melbourne, I think, Sydney, New South Wales, looked at the rate of psychosis amongst young people who were going into prison for one reason or another. Very, very interesting. And there she found, she identified all the individuals, undertook CARMs and other assessments, and the rate of psychosis in that group was amazingly high. And they are a group who have all the social risk factors come together that are partly involved in why they are entering prison. They come from difficult backgrounds, often backgrounds of neglect and abuse, but also other things. They're involved in drugs and so on. So this is really, really important. That was a long introduction, but very important because what we've done in this study, in the GetUp study, is to measure childhood adversity and experience. And there's been a lot of data on the links between that and the symptoms of individuals present with. I'm going to present you the analysis of these data, this approach from the GetUp study. Okay, well, as I say, the links between adversity and first episode psychosis are generally well established. As Paul Bevington has done some really good prospective work, and Jim Van Os and others on developing psychosis. It's now pretty clear. What we don't know, what the mechanisms are, it's a bit of a black box. I'll talk about that right at the end. And the interesting question, is this just an accumulation of adversity? The more adversity you have, the more likely you are to have more severe symptoms. Or is it a bit more differentiated? Do certain kinds of symptoms are associated with certain kinds of symptoms of psychosis? And this is what was explored by Rosa with our support in this study, whether there are particular kinds of childhood adversity that were linked with particular kinds of symptoms of psychosis. So we had two core hypotheses that were underlying this. Hypothesis 1 is that those individuals with any childhood adversity will have more severe positive and also affective symptoms, because it's well established in mood disorders and elsewhere, the link between adversity, abuse, neglect, and affective symptoms. So we thought that would be that was one of our hypotheses. Secondly, the acts of commission of abuse, physical or sexual abuse, will be specifically associated with positive symptoms. That's what the evidence was saying. And here is the differentiation. We're interested in whether acts of neglect, social neglect or other forms of intellectual neglect from parents or caregivers will be associated with negative or affective issues. So we're interested in that differentiation there in the nature of the childhood experience. So in the distinction in overt physical, sexual, emotional abuse versus neglect, does that have any general bearing on the presentation of these individuals? Well, I think this is probably a slide that Mirella is probably better explaining, but I think you showed this one this morning, I think. And here, this is really just a diagram that summarizes that all these individuals, 444 individuals, went into the study. They were assessed at the beginning and stabilized, and then they were randomized in the way that Mirella described this morning. And the data were collected right at the beginning during the stabilization phase, at the baseline phase. And so measures were taken of abuse and neglect, which I'll tell you about in a minute, and their presentation right at the very beginning. So we've got the usual suspects here, the positive and negative syndrome scale, depression measured by the Hamilton scale, and functioning. And we also, Mirella and colleagues, I should say, also measured childhood adversity and prior to age 17. And we were able to identify that from about 80% of the whole sample, which is very, very good indeed, amounting to an impressive 36 people. So the schedule used was the Childhood Experiences of Care and Abuse questionnaire, the CAREGIVING, and this has 4 scales. So this is a self-report scale. Of course, this is always one of the limitations of these studies. This is about people describing these things in retrospect. Very difficult to do this prospectively, but nevertheless, we'll come back to that a bit later. Physical abuse, sexual abuse, antipathy, and neglect. These are the 4 dimensions. It's a very well-used scale and has a number of cutoffs. So the methods were, we were interested in the outcomes in terms of PANS and functioning, and those were our predictors: abuse, neglect, antipathy, and neglect. And of course, whenever you do work like this, I've hinted at them already, there are hundreds of confounders around in a cloud. And the great advantage of a study like this is you've got so much, a big sample, enough to be able to try and tease out some of the confounders. You can never do it perfectly, but you can explore these data and control for all the potential confounders. We also did a sensitivity analysis, see if there were any independent effects of each type of trauma. Very difficult because these types of trauma generally overlap. Well, I'll come back to that in a minute. So the results. Result number 1 is just to look at the prevalence of childhood adversity using the cutoffs in the CAREGIVING. And here you go. It's just reminds me this morning of the paper I chaired from the prison population. Very similar, actually. The rate of any kind of adversity is enormously high, about 60%. That's an amazing figure. And it breaks down into bad parental relationships, antipathy, abuse, neglect, and also sexual abuse. And that's about par for the course, about 16%, what a lot of the studies find. But I think you can see there the potential power of this kind of social gradient being played out in this population here. So 35% had multiple adversities, and that's what you generally find. They don't, they rarely come alone, as you can probably imagine. So the second analysis was to look at any kind of adversity and their relationship to some of the key dimensions. that we're interested in. So in terms of a simple dichotomy there was an effect linking adversity and positive symptoms, depression, functioning, and also right at the bottom there, lifetime use of cannabis. And this is just like I was saying, the prison study, these individuals, these adversities tend to congregate and aggregate. And they're often associated with substance misuse. Really, really important area, I think. So number 2, and these are, have I got that right? Yes, I have. Number 3, and we're looking here at the relationship between the symptom dimensions and the different kinds of abuse. It's some of the results here are quite clear, others slightly messy, but let me just talk you through them. First of all, there was some clear links between remember, there was an overall link between overall PANSS. When you break down the PANSS, there's a link between grandiosity, very high odds ratio of 2.8 there, but also a similar link with antipathy in terms of grandiosity. In physical abuse, there were links with emotional withdrawal and with unusual thought disorder, and parental neglect, very clear links with emotional withdrawal and social withdrawal. And the way my reading of this is that the relationship between neglect and antipathy and the negative symptoms and with depression are quite clear in terms of acts of commission, abuse of various sorts, and positive symptoms overall there, but it's not, the data get kind of slightly noisy when you drill down, it's not quite as clear, but the overall relationship is there. So when you looked at the sensitivity analysis, well, guess what? All these things congregate. It's very difficult to do a sensitivity analysis. But when you looked at some of the individual sources of abuse, those individuals who had one kind of abuse without any other kind, the relationships also remained intact. Although you're talking here about very, very small numbers, but that was the results of the sensitivity analysis. Okay. So in line with the first hypothesis then, the first episode patients with a history of any adversity showed a more severe profile of clinical symptoms than those who were not exposed. Positive symptoms, depression, very important, and also global functioning. And just make sure I've not done that right. Yep. So high levels of positive symptoms and their link with adversity was, very much in keeping with the existing evidence base. Equally for depression, very important. Depression is a very clear, important dimension of schizophrenia, even though we like to call it, or we pretend it's a non-affective disorder. It isn't really. And thirdly, also this chimes with other results about the links here between these adversities and global functioning. So there was as I say, there was the link between abuse and antipathy and grandiosity and unusual thought content. The positive dimension was there. And with neglect, there were very clear relationships with items on the negative syndrome scale, emotional withdrawal, apathetic passive withdrawal, active social avoidance. So there's that broad relationship, which I think is quite clear from these data about acts of omission, of neglect, and antipathy and abuse seeming to have differential impacts once all these confounders were controlled. I'll just leave that one for the moment. So that's the overall findings. Overt physical, sexual, emotional abuse linked with positive symptoms, and neglectful environment linked to negative symptoms. There's a bit of a black box there about what that is. There's issues, for example, about stress sensitivity, about biological mediators. These are all for the future. But I think the data here, I'm convinced that there is an overall relationship in the way I've just described. Now, of course, it's very difficult when you're doing work like this, when you're measuring these things in retrospect, but I think the strengths of this are very clear. It's a very large sample, well characterized, and we had a high response rate on the main variable, which is the seeker. Good adjustment for confounders, but of course it's cross-sectional and a lot of retrospective data, and some forms of adversity have a low prevalence. So the last two slides, if I may Mirella. Is it cause, is it effect, or is it both? What's the mechanism? Well, it's very difficult to deal, particularly if you're dealing with changes across the early lifespan, the early years of people with psychosis. It's difficult. It could be a cause, it could be effect, but it also could be transactional. I suppose when you're involved in studies like this and you say, well, is it cause or effect? You always think, oh, is there an intervention that can help to sort this out? And it's and the interventions have yet to be done. I'll just point you to one clue, I think, and that is that studies on PTSD, which are widely documented in psychosis, about between 15 and 20%, and the intrusions that people get in PTSD in psychosis are predominantly about early trauma. That's a big smoking gun, but also about the trauma of treatment. I'll just draw your attention to this finally, which is a study, a big trial led by Mark van der Haag and colleagues on EMDR, and these are kind of standard interventions for PTSD, and showed a big impact on the reduction of PTSD. And you'll see here the numbers of those individuals with PTSD in all the groups who had different kinds of abuse: sexual abuse, multiple abuse, physical abuse, traumatic, and emotional abuse. These are just the kind of figures that I just described earlier. And the question is whether, and we don't know, I don't think the data are available, whether this kind of intervention, a PTSD intervention, could actually have some beneficial impact on A, the affective dimension in psychosis, and B, also on the symptoms, the positive and negative symptoms of psychosis. Very exciting possibilities for the future. So at that point, I'll leave it, and thank you for your attention.
Very clear. I wish to add
Sure,
that
please.
you said that, of course, this paper is sectional, but we are planning to write a second paper using the follow-up data aimed to get some understanding if the outcome of care, of the intervention in this group of patients which have more severe childhood adversities is worse, and also which is the appraisal and effect of the experimental intervention, looking also at some qualitative data from the...
That will help to untangle a lot of the cause-effect issues. I think it'd be very, very interesting. So our final speaker is Juliana Unwumere. I probably mispronounced that. Thank you. And Juliana works with Liz Kuipers and Paul Bebbington, and this group have been responsible for doing a lot of the training and support on this dimension of the GET-UP trial. And we're going to be hearing today about moderators and predictors of treatment outcome in caregivers. So please, take it away.
Thank you, Mirella and the group. I promise to be quick, given that it's our last one before the evening meal. Okay, so we know that informal carers play a significant role in first episode psychosis and outcomes. Okay, can you hear me now? Brilliant. So I was going to say that we know that informal carers play a significant role in first episode outcomes, and there are high rates of co-residency at this time. So if you look at the work of the late Helen Lester and their review of UK early intervention services, we know that the support received by family carers is valuable and valued both by patients themselves and families and service providers. We also know that family support can play a significant role in reducing relapse and hospitalisation. And more recent work just showing that family support can have a positive impact on mortality rates for first episode patients. However, running alongside this, and something not to be missed when we're thinking around family carers and support, is the high levels of psychological distress that we find in our family caregivers. And this is particularly elevated in the first episode stage, in the early illness phases, when people are not so sure about what's going on or what's actually happened to their family. But perhaps most importantly for us, we know that these levels of distress don't just disappear after the first day or the first week. They can be persistent. If you follow people up, they can kind of last over many years. When we're thinking about difficult or negative relationships in caregiving, or indeed any kind of mental health problem or physical health problem that extends over a period of time, we know that high EE presentations, and those are relationships that tend to be characterised by perhaps high levels of criticism and intrusive and negative behaviours, can be found in most relationships, but approximately about half will be found in first episode relationships. Why it's of interest in terms of me raising it today, because we know that high levels of EE, as well as high impact of care, tend to be positively related. But both of them together tend to be more associated with how carers think about difficulties, their appraisal of problems rather than just the presentation. And again, what's of interest is that these things, these difficult types of presentations in caregiving relationships, are also associated with more responsibility attributions. And by that, I'm referring to where carers might attribute blame and responsibility to the patient for their difficulties and not quite see their illness as an illness, and maybe view it as something that they're doing deliberately, and if they wanted to stop, they could, but they're choosing not to. Another important part of relationships is not just what the carers are thinking, but more about what the patient thinks, their perception of the relationship and how it works. And we know that service users and patients can accurately perceive criticism and negativity from their primary caregivers. And what's more important for us is we know that those perceptions in and of themselves can also be important for outcomes. We know that this can happen even at first episode stage, so where you're perceiving more negativity or criticism from your carers, that can be associated with more mood disturbance. So much of this work in different strands is very much reflected in or driven in our treatment guidelines that we have, in psychosis, whether they're UK-based, American-based, and very much the model of these recommendations are psychosocial provision, CBT, family interventions, case management, that type of work. However, what should be of interest to us here when we're certainly talking about families is we don't really know so much in terms of what might be some of the moderators of better outcomes, or indeed some of the predictors. Much of the discussion on this area, certainly as it relates to families, is that we don't have enough of it, there's not enough provision. Or we know that families, what they think of the interventions, certainly around family interventions perhaps, but nothing too much about the moderators or the predictors. Some recent work is now showing some of the mechanisms and how it might work, but again, not really about the moderators. So the aim today is just to present some preliminary results really from the Get Up work, where we're wanting to think about what are some of those pre-treatment characteristics, what are those predictors or moderators of care outcomes from psychosocial treatments. And we're specifically wanting to look at what are some of the better treatment responses, irrespective of the intervention that people have received, but also what are the moderators? As we heard earlier this morning from Marilla, and indeed others, that actually when we focus on some of the moderators, those can help us to develop very clear questions or certainly hypotheses about clinical effectiveness, and particularly at times when resources might be short. I'm not going to go over the Get Up programme because I think you've heard it now quite a few times. So what we're wanting to look at is what really were the best predictors and moderators of carer outcomes at 9 months. The main outcomes we were focusing on were a burden measure, the involvement evaluation questionnaire, and a measure of emotional distress, the GHQ. In terms of the predictors and moderators, these were done without a specific hypothesis, but very much looking at indications from the literature. So a real combination of sort of clinical and demographic characteristics from both patients and carers, but also looking at perceived carer criticism, as you've heard from the SEAC measure that Max was talking about earlier, and levels of expressed emotion as perceived and reported by the patient, and also their experiences of early caregiving. Obviously, in terms of the intervention, there were people that didn't complete, but we knew that there was no difference, no significant differences in demographics and outcome, with the exception of the GHQ in those that didn't complete. So when we think about, those two strands here, you've got the experimental group who are having this sort of multimodal psychosocial intervention of CBT, family interventions, and good case management, and treatment as usual. No differences at baseline between sort of key outcomes in terms of demographics. And again, no significant differences between the two groups in terms of some of the key factors that we're looking at around EE and perceived criticism. Okay, so what did we find in terms of what were the key predictors, certainly for carers, at their outcomes at 9 months? We found that patients' perception of mother's early criticism, so you can look at it from relation to the father and indeed the mother, but it's the mother's early criticism that seemed to predict lower levels of carer burden in the form of worry at 9 months, and this was irrespective of the treatment allocation. However, this result didn't stand after analysis to kind of following sort of multiple analysis. If we move on now from the predictors, but actually what moderated treatment outcomes? We found that in this group that higher levels of carer burden, specifically measured as intention, the tension that carers can experience, moderated greater reductions in emotional distress at 9 months. So those were reporting much higher levels of carer burden at baseline. It moderated greater reductions in emotional distress. Perceived carer tolerance. Those are beliefs where carers, patients believe that their carers don't believe that they're very well. They feel that they're doing something on purpose, that they're not ill. That moderated carer burden in terms of tension at 9 months. And equally, we found that carer age moderated carer burden, certainly in terms of the younger carers. Feels much better just to explain it in terms of the summary. So we didn't really find in terms of certainly a predictor that was maintained. So patient perception of early criticism, a sort of sense of having quite a difficult or critical relationship, might have served as the only key predictor of carer burden, but this result wasn't sustained. But I guess the key take-home messages here are that higher, when we're working with carers that report higher pre-treatment levels of carer burden, these carers that are particularly burdened in the beginning, and as measured in terms of tension, they seem to have done better in terms of emotional distress, certainly in our experimental group. Where there was patient perceptions of carer intolerance towards them, so these are carers who might not believe or certainly presenting as not thinking that their relative was unwell or had symptoms of illness. They seem to do better in terms of reductions of worry at 9 months. And carer age, in terms of younger carers, in terms of our median split, those are carers sort of below the age of 51, they seem to do much better in terms of in our experimental group when we followed them up at 9 months. In terms of the discussion, and I think I've always found it quite interesting, certainly talking with Morella and others, about actually what happened here, because I think sometimes it can get lost. You're hearing about a big study and it's really fantastic, multi-millions, but actually what does this mean? These were regular teams. These were regular teams being able to integrate this work. And it showed in many ways that, just doing the intervention could be beneficial, certainly to quite a broad and representative group. These were people that were just in regular services. It wasn't a specialist services. They're in routine community mental health services. But what we found that in terms of groups that might do particularly better in terms of certainly with the intervention are our younger carers, as in terms of below 51. Carers who were reporting very high levels, pre-treatment high levels of carer burden, those are the groups we're particularly thinking about. And the groups where caregiving relationships are very much characterised by a sense where carers might not believe that their relative is unwell, that they might believe that this isn't an illness. Those are the groups that might be quite helpful to target, in addition to everybody. Yes, I mean, certainly, as Matt has presented before, there are limitations, as there are with many studies. And it was exploratory, certainly in terms of the selection of the moderators. But I think it is important to acknowledge that actually, when you're looking in the research and the literature, much of our discourse on family work and CBT work in relation to families and outcomes has very much been about provision and access. Nothing really about moderators and actually what can make the difference. Obviously, it needs to be replicated in terms of the actual approach and the intervention in other geographical contexts. You heard from Mirella this morning and others that this was specific to sort of northern regions within Italy as well. And collection of longer term outcomes. This is at 9 months. Be interesting to see how this develops at 2 years and beyond. And I think I've done it in time. Thank you.
Wonderful. That's fantastic. Colleagues, any questions or comments finally? Juliana, I was going to ask you about a question I've always wanted to ask about is there any greater understanding about what is driving expressed emotion, and why some individuals have high criticism and high over-involvement? Is it? I touched on this work many years ago, not so much involved in it. Is there? How do you understand that differentiation?
I think, I'll just stand up as well. I think, there's a lot more work looking at carers' key appraisals. So even the work that you did with Paul Patterson, just looking at the importance of loss, and how that can drive and certainly impact on emotional over-involvement, which is really quite important. And just I think an important move away from what was around before, that it's about symptoms, it's just about symptoms, it's just about the amount or the severity, but actually has a lot more to do with how carers are thinking about things, which is quite important. If you look at first episode carers, some work done by McNabb in Australia, finding that these carers who were presented as being quite critical, it wasn't a surprise to them, it was an understandable thing, because that's what they thought would help affect change and positive change and deliver those behaviours.
Right.
So
interesting.
Really thinking about how carers are conceptualising not just the illness but all the related difficulties. And I think it's more problematic at first episode, because if you kind of think about the time when people first become poorly, it's for many people it's quite hard to disentangle what is illness and what was my son, just he's always been a bit like that.
Yeah.
That's a bit difficult, so.
Okay, well, can I thank you all for staying here till the bitter end?
Yes.
And this has been, thank you to Mirella for organising this meeting, and of course for leading this project, and well, have a good evening. Thank you.
Thank you.